Code Blue. Corridor 3 East, the hospital intercom announced as DR. Sarah Mitchell collapsed suddenly outside the ICU, her face flushed and breathing labor from what appeared to be a severe allergic reaction. Medical staff rushed toward the emergency, but David Thompson, the night shift janitor mopping floors nearby, immediately dropped his equipment and moved with a speed and precision that stunned everyone present. "Step back, give her room," he commanded with quiet authority as he knelt beside the unconscious doctor, his hands moving with practiced efficiency to check pulse, airway, and breathing patterns. What the gathered medical staff didn't know was that the man in the janitor's uniform performing flawless emergency medical assessment was Staff Sergeant David Thompson, former Army combat medic, who had saved hundreds of lives on battlefields across Afghanistan and Iraq before choosing to serve in a different kind of medical mission. David Thompson, 39 years old, had been working the night shift as a janitor at Metropolitan General Hospital for 2 years and 4 months, maintaining the same quiet professionalism that had characterized his 12 years of military medical service. Every evening at 10 p.m., he arrived wearing the standard hospital maintenance uniform, carrying basic cleaning supplies, and beginning the methodical process of ensuring that one of the city's busiest hospitals remained clean, safe, and ready for the constant flow of medical emergencies. The hospital staff knew David as the efficient, reliable custodian who worked with minimal supervision and somehow managed to clean entire wings of the hospital without disrupting patient care or medical procedures. He moved through corridors and patient rooms with a quiet competence that hospital administrators appreciated, completing his duties thoroughly while remaining practically invisible to the complex medical operations happening around him. What they didn't notice was the way David's eyes automatically scanned medical equipment as he cleaned around it, checking for proper function and positioning. The way he organized his cleaning supplies with the same systematic precision used for medical kits in combat zones. The way he moved through the hospital with situational awareness that went far beyond what custodial work required. David had chosen hospital maintenance work specifically because it allowed him to remain connected to medical environments without the high-stress responsibilities of direct patient care. After 12 years as an Army combat medic, including 5 deployments to Iraq and Afghanistan, he had seen enough medical trauma to last several lifetimes. His military medical training had been extensive and intensive: advanced trauma life support, battlefield medicine, emergency surgery assistance, and medical evacuation procedures. He had treated everything from routine combat injuries to complex trauma cases that would challenge doctors in well-equipped civilian hospitals. But he performed this work in conditions where medical supplies were limited, evacuation was dangerous, and medical decisions had to be made instantly under enemy fire. When David retired from the Army, he had initially considered civilian medical careers that would use his training more directly: paramedic work, emergency room technician positions, or military contractor medical support. But after years of high-stakes medical emergencies, he had chosen maintenance work because it offered the satisfaction of supporting medical care without the constant pressure of life-and-death decisions. The irony wasn't lost on David that he was cleaning the same types of medical equipment he had once operated, organizing the same medications he had once administered, and working in sterile environments similar to the field hospitals where he had spent years saving lives. But the transition from treating battlefield trauma to maintaining civilian medical facilities felt like a healthy step toward peaceful application of his experience. Metropolitan General Hospital was a Level 1 trauma center, serving a diverse urban population. The facility treated everything from routine medical issues to complex emergency cases, and David's night shift meant he worked during the hours when the most serious emergencies typically arrived. During his 2 years at the hospital, David had witnessed numerous medical emergencies from the perspective of support staff rather than medical personnel. He had seen cardiac arrest, trauma cases, and critical care situations handled by doctors and nurses with skills and equipment that impressed him even with his military medical background. But David had also noticed things that medical staff, focused on immediate patient care, sometimes missed. Equipment positioned inefficiently for emergency access. Supply organization that could be improved for faster response times. Environmental factors that could be optimized to support better medical outcomes. David made quiet suggestions to nursing staff about these improvements, always framing them as observations from custodial work rather than medical expertise. His recommendations were consistently helpful, leading some staff members to comment on David's unusually good understanding of hospital operations for someone in maintenance work. David, said nurse manager Patricia Rodriguez during one of their occasional conversations, you have really good instinct about hospital efficiency. Have you ever considered medical training? I've picked up some knowledge working around medical facilities, David replied, which was technically accurate while revealing nothing about his Army Medical Corps background. The evening when everything changed began routinely. David was cleaning the third-floor corridor outside the ICU, working around the normal flow of medical staff, visitors, and equipment that characterized the hospital's night operations. Dr. Sarah Mitchell, a 34-year-old emergency medicine physician, was completing rounds before ending her shift. Dr. Mitchell had been working at Metropolitan General for 3 years and had developed a reputation as one of the most skilled emergency physicians on staff. David knew her by sight as someone who worked long hours, maintained professional demeanor under pressure, and treated support staff with consistent respect. At 11:47 p.m., David was mopping near the ICU entrance when he heard Dr. Mitchell speaking with a nurse about a patient medication concern. The conversation seemed routine until David noticed Dr. Mitchell's voice becoming strained, her speech pattern changing in a way that suggested respiratory distress. David looked up from his cleaning to see Dr. Mitchell reaching toward the wall for support, her face flush red, her breathing becoming labored and rapid. As someone trained to recognize medical emergencies instantly, David immediately identified the symptoms as anaphylactic shock, a severe allergic reaction that could be fatal within minutes without proper treatment. Dr. Mitchell collapsed before reaching the wall, hitting the floor as her breathing became increasingly difficult. The nurse she had been speaking with screamed for help, and the hospital's emergency response system activated with the announcement, Code Blue, Corridor 3 East. Medical staff began rushing toward the scene, but David was already moving. His combat medic training had drilled into him that the first 60 seconds of a medical emergency were critical, and that waiting for official medical personnel could mean the difference between life and death. David immediately knelt beside Dr. Mitchell, his hands moving with the practiced efficiency of someone who had performed medical assessments hundreds of times under much more difficult conditions. He checked her pulse, rapid and weak, her airway partially obstructed by swelling, her breathing shallow and labored, her skin flushed and developing hives consistent with severe allergic reaction. Step back, give her room, David commanded with quiet authority that surprised the gathering medical staff. She's in anaphylactic shock. We need epinephrine immediately. Dr. James Patterson, the attending physician responding to the Code Blue, arrived to find David performing a medical assessment with a level of competence that seemed impossible for hospital maintenance staff. Sir, please step away so medical personnel can respond, Dr. Patterson said. Doctor, I am medical personnel. David replied without looking up from his patient assessment. She needs epinephrine now, and we need to prepare for possible intubation. Her airway is compromising rapidly. Dr. Patterson was about to order security to remove David from the scene when he noticed precision of David's medical evaluation. The way he was checking vitals, assessing respiratory function, and monitoring neurological responses demonstrated advanced medical training that went far beyond first aid knowledge. Nurse Rodriguez, who had arrived with a crash cart, recognized David's voice and professional demeanor from their previous conversations about hospital efficiency. Dr. Patterson, she said quietly, I think we should listen to him. David knows more about hospital operations than any maintenance worker I've ever met. Dr. Patterson made a split-second decision to trust David's assessment. What do you need? 0.5 milligrams epinephrine intramuscular, large bore 4 access, high flow oxygen, and have intubation equipment ready in case the airway compromise progresses. David responded with a rapid, precise communication style used in emergency medical situations. As the medical team followed David's recommendations, Dr. Mitchell's condition began to stabilize. Her breathing improved, her blood pressure increased, and her consciousness level started to return to normal. Dr. Patterson, who had been practicing emergency medicine for 15 years, realized that David's immediate assessment and treatment recommendations had probably saved DR. Mitchell's life. Without rapid epinephrine administration, anaphylactic shock could have resulted in cardiac arrest or death within minutes. Sir, Dar, Patterson said to David as paramedics arrived to transport DR. Mitchell to the emergency department for continued observation. That was excellent medical response. What's your medical background? David hesitated, the way he always did when asked about his qualifications. Army medic, sir, 12 years. Just Army medic training? Combat medic, sir. Multiple deployments. DR. Patterson understood immediately. Combat medics receive medical training equivalent to civilian paramedics, but with additional trauma experience that often exceeded what civilian medical personnel encountered in entire careers. How long ago did you leave the Army? 2 years, sir. And you've been working as a janitor here for 2 years? Yes, sir. DR. Patterson realized that Metropolitan General Hospital had been employing someone with elite medical training as custodial staff, and that David's expertise could have been invaluable for medical operations if anyone had known about his background. The conversation that followed, conducted in DR. Patterson's office after DR. Mitchell had been stabilized and admitted for observation, revealed the extent of David's medical experience and his reasons for choosing maintenance work over direct medical practice. Staff Sergeant Thompson, DR. Patterson said, using David's military rank after reviewing his credentials, your medical response tonight was exceptional. DR. Mitchell owes her life to your rapid assessment and treatment recommendations. Thank you, sir, but any medic would have done the same. That's not true, and you know it. What you did required advanced medical knowledge and the confidence to take charge in a crisis situation. Why aren't you working in a medical capacity? David explained his transition from military to civilian life, his decision to step away from high-stress medical situations, and his preference for supporting medical care rather than providing direct patient treatment. Sir, after 12 years of battlefield medicine, I needed work that was connected to healthcare but didn't require constant life-and-death decisions. Maintenance work lets me support medical operations without the psychological pressure of direct patient responsibility. DR. Patterson understood the challenge of transitioning from military medical service to civilian healthcare, but he also recognized that David's skills were too valuable to waste in custodial work. David, would you consider a hybrid position? Something that would use your medical expertise for training and emergency response, but wouldn't require you to work as primary medical staff. The position DR. Patterson proposed was Medical Operations Coordinator, a role that would involve training hospital staff in emergency response procedures, maintaining medical equipment, and serving as backup medical support during major emergencies. David was initially reluctant to return to medical work, but the position offered a compromise between using his expertise and avoiding the constant pressure of primary patient care responsibilities. DR. Patterson, I appreciate the offer, but I'm not sure I'm ready to return to medical work. David, tonight you prove that your medical instincts are still sharp and that you can perform under pressure without being overwhelmed. This position would let you contribute your expertise while maintaining boundaries that protect your mental health. After a week of consideration, David accepted the position. The transition from janitor to medical operations coordinator represented a return to medical work, but in a context that felt sustainable rather than overwhelming. David's first responsibility was developing emergency response training for hospital support staff. His experience with battlefield medicine provided unique perspectives on crisis management, resource conservation, and maintaining performance under extreme pressure. The principles of emergency medicine are the same, whether you're treating combat injuries in Afghanistan or responding to medical emergencies in a civilian hospital. David explained to a group of nurses during one of his training sessions. Rapid assessment, efficient treatment, clear communication, and systematic approach to crisis management. The training programs David developed were based on military medical protocols adapted for civilian healthcare environments. Hospital staff learned techniques for managing multiple casualties, conserving medical supplies during emergencies, and maintaining calm professionalism during high-stress situations. Dr. Mitchell, who had recovered completely from her allergic reaction, attended one of David's training sessions and thanked him personally for his life-saving response. David, I want you to know that your quick thinking and medical expertise saved my life. If you had waited for the official medical response, I might not have survived. Dr. Mitchell, I was just doing what any medic would do in that situation. No, you did what someone with exceptional medical training and the confidence to act under pressure would do. There's a difference. Dr. Mitchell's recovery became a turning point for David's perspective on his transition from military to civilian medical work. He realized that stepping away from direct patient care didn't require abandoning his medical expertise entirely, and that there were ways to contribute to healthcare that didn't recreate the trauma and stress of battlefield medicine. 6 months after his promotion to Medical Operations Coordinator, David received recognition from the hospital administration for developing training programs that had significantly improved emergency response capabilities. David, said Hospital Administrator Karen Williams during a staff meeting, the emergency response protocols you develop have reduced our average response time by 40% and improved coordination between departments during crisis situations. But the recognition that meant the most to David came from medical staff who had benefited from his training and expertise. Staff Sergeant Thompson said to R. Patterson during a quarterly review, "Your contribution to this hospital goes far beyond your official job description. You've helped us become better at what we do, and you've probably saved lives through improved emergency procedures." David had also begun mentoring other veteran medical personnel who were transitioning to civilian healthcare careers. His experience balancing military medical training with civilian work requirements made him valuable for helping other veterans find sustainable paths in healthcare. The key, David explained to a group of veteran medics considering civilian medical careers, is finding ways to use your military medical training that align with your personal goals and mental health needs. There are many ways to contribute to healthcare beyond direct patient care. A year after the incident with Dr. Mitchell, David received an unexpected opportunity that connected his current work with his military experience in a new way. The Army Medical Command contacted David about developing training programs for combat medics transitioning to civilian healthcare careers. His experience with both military battlefield medicine and civilian hospital operations made him uniquely qualified to help design transition curricula. Staff Sergeant Thompson said Colonel Maria Santos during a phone conversation, "We need someone who understands both military medical training and civilian healthcare requirements. Your work at Metropolitan General has been brought to our attention as a model for successful transition." David accepted the consulting position while continuing his work at the hospital. The combination allowed him to help other military medical personnel while continuing to apply his expertise in civilian healthcare settings. The training programs David developed for transitioning combat medics emphasized finding civilian medical roles that matched individual goals and psychological needs, rather than assuming that all military medical personnel should pursue the same types of civilian careers. Military medical training provides excellent preparation for civilian healthcare careers, David explained to a group of transitioning medics. But the transition requires understanding how to apply those skills in environments that are different from military medical operations. 2 years after saving Dr. Mitchell's life, David had become a recognized expert in veteran medical career transitions and was regularly invited to speak at military medical conferences and veteran employment events. But David continued working at Metropolitan General Hospital, maintained his role as Medical Operations Coordinator while developing new programs for emergency response training and veteran medical career support. Dr. Mitchell, who had become a close colleague and friend, often reflected on how David's immediate medical response had not only saved her life, but had led to improvements in hospital emergency procedures that had benefited countless patients. "David," she said during one of their regular conversations, "when you saved my life that night, you probably didn't realize you were also starting a process that would improve medical care for thousands of patients." David realized that Dr. Mitchell was right. His decision to act during a medical emergency had led to opportunities to apply his military medical expertise in ways that supported civilian health care while maintaining the psychological boundaries he needed for sustainable work. Dr. Mitchell I think I've learned that transition from military medical service doesn't require choosing between using your skills or protecting your mental health. It requires finding ways to apply those skills that align with your values and personal needs. Today, David Thompson continues working at Metropolitan General Hospital as Medical Operations Coordinator, developing training programs that improve emergency response capabilities and helping veteran medical personnel transition to civilian healthcare careers. The cleaning cart he once pushed through hospital corridors has been replaced by medical training equipment, but David's approach to his work remains the same: quiet competence, systematic efficiency, and dedication to supporting medical care in whatever capacity serves both patients and healthcare workers. Hospital staff who worked with David during his custodial days often comment on how his medical expertise was evident even when he was performing maintenance work, and how his transition to medical operations seemed natural rather than surprising. David's story reminds us that military medical expertise doesn't diminish when applied to civilian healthcare, it enhances. That combat medic training can improve civilian emergency response just as effectively as it saves lives in battlefield conditions. That the same skills used to treat trauma in combat zones can be used to develop better emergency procedures in civilian hospitals. The next time you see a hospital maintenance worker, remember David Thompson. Remember that they might have medical experience gained in situations and places you can't imagine. Remember that they might have chosen support roles not because they lacked medical qualifications, but because they found meaningful ways to contribute to healthcare without recreating the stress and trauma of their previous medical service. Sometimes the most important medical interventions happen not in operating rooms or emergency departments, but in hospital corridors where quiet professionals use extraordinary training to save lives during unexpected emergencies. Sometimes the greatest medical expertise belongs to people wearing maintenance uniforms rather than medical scrubs. We need to recognize and appreciate the skilled medical professionals among us who've chosen to serve healthcare quietly, especially those whose previous medical service required treating trauma in dangerous places, so that civilians could receive medical care in safe ones. Because true medical expertise doesn't disappear when uniforms change, it just finds new applications. And sometimes the most valuable medical training involves not performing surgery or prescribing medications, but recognizing emergencies instantly and responding with a confidence and competence that can mean the difference between life and death.